Hi, and welcome to the Nutrition Corner for the IBD Journal Club. I'm Kelly Issokson, and today I'll be discussing the article entitled Randomized Clinical Trial, Exclusive Enteral Nutrition versus Standard of Care for Acute Severe Ulcerative Colitis. Acute Severe Ulcerative Colitis, or ASUC, is defined by True-Leavenworth's criteria and is a medical emergency requiring hospitalization and time-sensitive management. It affects 15 to 25% of patients with ulcerative colitis in their lifetime. IV corticosteroids are the mainstay of therapy, but 30 to 40% of patients fail to respond and require salvage medical therapy or colectomy. Salvage therapy is limited by side effects, cost, and about 50% of patients relapse and need surgery in the long term. EEN, or exclusive enteral nutrition, is a nutritional therapy where 100% of nutrient needs are provided by a formula. EEN is thought to act through local and systemic immune modulation, modifying intestinal inflammation, barrier function, and the gut microbiome. It's effective for inducing remission in Crohn's disease, but there's positive evidence for its use in UC. The aim of this study was to investigate EEN as an adjunctive therapy to IV corticosteroids in patients with ASUC. Their primary outcome was corticosteroid failure, defined as need for salvage medical therapy or colectomy. This was a single-center, open-label, randomized clinical trial where patients were randomized to either standard of care, which included normal diet along with standard medical therapy, or EEN, which included semi-elemental formula. They used peptamen for 7 days along with standard medical therapy. Patients were excluded if they received IV corticosteroids before admission, those less than 18 years of age, those with infective colitis or Crohn's colitis, those with complications, or those requiring emergency colectomy without steroids. There was slow recruitment due to the COVID-19 pandemic, and the trial was actually halted. They screened 75 patients over 21 months, 13 were excluded, and they ended up with 62 patients which they randomized to either the EEN arm or the SOC arm. The mean age of patients was 35 years, 40% were male. The median disease duration was 36 months. 74% had pancolitis, 8% had ASUC as their index presentation. 57% and 10% had already received azathioprine and anti-TNF therapy, respectively, and there was no significant difference between groups for baseline demographics, disease duration, phenotype, endoscopic severity, CMV, or admission, CRP, fecal calprotectin, or other biochemical parameters. 27 of the 32 patients in the EEN arm completed their 7 days of EEN by mouth. The average intake was 1421 calories and 50 grams of protein per day. 16% were intolerant and discontinued EEN before the 7 days. Those on the SOC had comparable calorie and protein intake. In looking at the intention to treat analysis, there was no significant difference between groups for corticosteroid failure. But when looking at the per protocol analysis, corticosteroid failure was significantly lower in the EEN group compared to standard of care. There was no difference in colectomy rate or response to salvage therapy, but the EEN group had a significantly shorter length of stay. The EEN arm had a significantly higher day 7 albumin, a greater reduction in serum CRP, and fecal calprotectin. In patients with more than 6 months of follow-up, there was a significantly lower composite outcome of colectomy and hospitalization at 6 months in the EEN group compared to the SOC group. Fecal microbiome analysis was done in a subgroup of patients. There was no significant difference in microbial composition baseline or in alpha diversity or beta diversity, but patients on EEN did have an increase in abundance of erysipelotrichase on day 7 and a reduction in bifidobacterium and valinolacea compared to standard of care. In conclusion, EEN for 7 days may augment response to corticosteroids in acute severe ulcerative colitis. This is a small study with some limitations, but I think it's worth noting the decrease in the corticosteroid failure rate, as well as the hospital length of stay, and the decrease in composite outcomes of colectomy and hospitalization in the EEN arm. And really, I think begs the question of whether or not we should be using this more in our ASUC patients. We definitely need to see more studies on this.